Welcome to the Preventive Medicine Podcast. Help us change the paradigm of medicine from keep people alive to help people thrive, one episode at a time. And now, here's the show.
So with all this being said about kind of keeping people out of hospitals, I think one of the things we would all agree that is a big part of that is exercise. I mean, one of the strongest recommendations we can give people is exercise. And I think, one of the things that I think a lot of even clinicians don't realize is that the current guidelines for exercise are relatively robust in terms of the amount of resistance training they're recommending and the amount of vigorous exercise or moderate intensity cardiovascular exercise. It's a pretty robust amount of exercise. And I think, or I guess I should say, do you think that we do a pretty poor job of explaining to patients that hard exercise is something you should be striving for?
Yeah, so I think that this is definitely a nuanced conversation, as we'd say. I
was waiting for you to drop that word.
I agree that the amount is pretty substantial. So, 150 to 300 minutes of moderate intensity, 75 to 150 minutes of vigorous intensity, and 2 to 3 resistance training days per week. That's a lot of work for most people. And I think that, it is definitely, there's a large and robust body of evidence that if we can achieve those as minimums, then we can have enormous health implications and benefits for people. However, I think that it's also important to recognize that there's no minimum threshold for benefit here either. There is no minimum threshold at all, and there's a dose response effect with respect to the training volume that you do. So you can start out with a little and get a pretty substantial amount of benefit, and as that volume dose increases, you get incremental benefits over time. Definitely, I think that clinicians' ability to confidently converse on this stuff is pretty poor overall across the board, including most primary care folks. Their ability to deliver this information in an effective way, i.e. using effective behavior change techniques, is pretty poor. Of course, it's also limited by the time they have available and things like that. How often do patients ever schedule appointments with the primary care doctor just to discuss exercise? Never. They don't do that. And so you're always forced to be cramming that in, maybe at the end of a visit, after you've discussed either a chief complaint, or if no complaints, there are other, multi-morbidities or their screenings or whatever, things that are potentially of lesser significance to their ultimate health outcomes compared to exercise. But that's kind of the world we live in right now. So I definitely think that there are communication issues, but there are problems at multiple other levels here. And I do think that, similarly to our conversation earlier, by starting out by trying to elicit where the patient is, can be more effective so that you can deliver them the information in a way that they can understand, and it can be a realistic starting point for them. So if you have a 65-year-old person with a few comorbidities who's never done anything physical in their entire life, giving them a piece of paper with these physical activity guidelines is equally effective as putting that piece of paper in the trash. It's not going to do anything. Whereas eliciting where they're at, what their goals are, what they're able to do, and proposing some specific things that they can do rather than just general things like move more. What does that even mean? So I think there are just so many ways that we can improve the way we deliver this message. It needs to be individualized 100% of the time. Based on their baseline abilities, their tolerance, their goals, their preferences, things like that. And there may be some patients who just straight up say, I'm not interested in doing this. And then that becomes a process that you might work on over time. They teach you guys in school. They taught me same way. If you have somebody who, is actively smoking and they say, I'm not interested, what do? You bring it up the next time. You don't just say, screw it, this person's never going to quit smoking. You just keep doing it because the benefits are so huge, right? Mm-hmm. So it's easy to, for some reason, we get uniquely jaded about the ability to actually elicit behavior change with respect to exercise, even though the evidence base we have on this says that we can change behavior, but you have to view it as an intervention that has its own unique number needed to treat, just like anything else. In other words, maybe it might take, if you really suck at this stuff, maybe your NNT for exercise related behavior change is like 500. You counsel 500 people, you might get one to actually change their behavior. Whereas if you are really, really good at this, maybe you can work that NNT down to, 20, 15, maybe 10 or something like that. That'd be super impressive, is if you can have potentially even lower by how many people you need to counsel before you can get one to change their behavior, even if a little bit, because again, there's no minimum threshold and there's a volume-based dose response to the benefits over time.
And that comes down a lot to, once again, currently where the system's at, because we talked about this in another podcast as well, where the incentives are, because getting a patient to change their behavior regarding exercise and nutrition is pretty difficult to do especially if they're like resistant to it. And it takes a lot of time. Yeah, it's very time intensive. And if you go to like one of those ICD-10 codes, it's not really on there because it prefers interventions, right? So the amount of time that physician has to spend to get a patient to do that is kind of not balanced how much compensation they get out of it, which is one of the major problems that hopefully gets fixed by the time we get further on in our careers. But I think that would be huge.
Yeah, I think so too. And the other thing that may end up emerging from this, and this is something that you already see in some primary care clinics with respect to nutrition, for example, is that there may be a dietitian in the clinic, and that they can function as a part of a modality, multi-specialty team, because it might not be feasible or realistic, or even it might not even be the right idea for a physician to be doing this counseling exclusively, because basically you want everybody in the clinic to be practicing to like the top of their like level of training and their license in terms of scope. And that might not be the best use of a physician's time in a situation where you might have access to somebody who can do that counseling effectively on their own and may have more time to devote to it. So there are, growing aspects to this kind of multi-specialty, multidisciplinary care, where maybe there is going to ultimately end up being, a dietitian who can handle that piece, maybe somebody who's like an exercise counselor, whatever title you might want to give them, who can help to facilitate that side of things. And that might, I would expect that would become more prevalent when the incentives align to facilitate that, of course.
I agree. I think one of the things as well that currently seems to be a barrier, but hopefully, I guess as social media and other outlets such as, you guys at Barbell Medicine spread a message of, exercise and nutrition and things that are actually important. There seems to be a disconnect between I guess I would say like personal trainers or fitness people and physicians in terms of, physicians get frustrated because so-and-so, this personal trainer with 1 million followers is selling some sort of, bullshit product. But then a lot of, personal trainers are like, well, the doctor doesn't know anything about nutrition or exercise or whatever. So, how do you, in your mind, what do you think the steps are towards bridging that gap between, okay, we have fitness professionals who know how and what to recommend and physicians who trust them to make those recommendations and vice versa? How do you see that playing out in the next decade or so?
Yeah. I'm not sure I see a ton of progress being made on that front. The next decade might be a longer period of time, but that's a reflection on my own views on a lot of things. But I mean, I think that it's easy to pick out examples of bad apples like that. There are people who espouse non-evidence-based or outright harmful information all over the place. And so that does not, that even includes physicians. I mean, physicians like to hate on a lot of other groups or specialties, or, say they might mock a lot of forms of complementary and alternative medicine. And by no means am I a huge fan of those things. But at the same time, if you're going to be doing that, I would expect that you're at least practicing in a pretty evidence-based fashion. And when we look at how often clinicians actually adhere to clinical practice guidelines on a lot of things, the biggest example being low back pain, they're doing a horrible job of it. They're by no means, they're sending all kinds of patients for early imaging. A tiny minority of them are getting physical therapy. A huge proportion of them are getting early opioids, all this stuff. And it's like, that's just as bad. That's arguably in many situations worse than what a lot of the complementary and alternative medicine practitioners are doing. And I would prefer that none of that be happening. But really, I think it's probably unhelpful to single out those kinds of like bad actors in the space. I think that overall, most people in medicine, most people in the personal training world are working to try to help people. But of course, that's not to say that most people in the personal training world are aware of the current physical activity guidelines either. They might just be doing things that make people really sore. They might throw something at somebody that's wildly inappropriately dosed and land them in my ER with rhabdo or something like that.
They might do MRF twice in one day.
I mean, if you're just a total idiot, you might do something like that. So I think that there is a large gap to be bridged there, but I don't think that that's something that can be forced on like a national level or something like that. I think it's going to be a more of a local phenomenon, needs to be done, through building relationships. And if I had to guess, that would probably need to involve the trainers going to the physicians than the other way around. I don't envision physicians going out and seeking out trainers that they can refer to. But if you're a personal trainer and you feel, comfortable and confident with what you're doing, then building relationships with physicians is probably going to be a good idea going in that direction. The only caveat is that, of course, what kind of people are the physicians seeing? They might be seeing people with multiple medical comorbidities that you need to be comfortable dealing with in your training practice. I'll say that most medical conditions don't need a ton of fancy, unique, exercise programming or monitoring or something like that. But of course, some of them do have some special considerations. That's the direction I see this kind of heading, is I think that more people in the training space need to be building relationships with physicians, because unlikely that it's going to happen the other way around.
Makes sense.
Preventive medicine is an incredibly important topic. I want to thank you for taking the time to watch this video. For the full episode, find us on your favorite podcast streaming platform. If you enjoyed this video, don't hesitate to hit that subscribe button, like this video, and share it to keep that message spreading. Thank you once again for watching this video, and we'll see you in the next one.